Excuse me. Thank you very much for inviting me to speak, and thank the organizing committee for asking me to talk on this interesting topic, pathway to hepatitis B cure, challenges and successes. Of course, I'm a bit like a fish out of water here in the midst of all you HIV and infectious disease doctors. I'm a hepatologist by training, and my focus is on hep B liver disease, obviously. So these are my disclosures. And I think the first thing I want to say is, what is hepatitis B cure? So some of you may not be very familiar with what is cure, because I think cure in HIV is a relatively uncommon event. But for hepatitis B, this did not used to be a common event, but we're hoping it'll be becoming more common. And the definition here is sustained S antigen loss seroconversion, 24 weeks of therapy with undetectable HBV DNA. And this is being decided by both the American societies and the European societies in an endpoint conference, at least 2 endpoint conferences they've had. Actually, you can get spontaneous S antigen loss or even on-treatment S antigen loss today, but the rate is low. It's about 1% per year. Ideally, what we want to see in phase 3 trials is about 30%. Now, this should be distinguished from what we call absolute or complete cure, where there's no cccDNA and absence of integrated HBV, which seems to be unlikely, but with the use of CRISPR-Cas9 and base editing, this might become possible in the future. One of the things about this endpoint of S antigen loss is whether it's really meaningful in terms of important clinical outcomes. And here's a meta-analysis that was published a few years ago, showing that if you have S antigen loss, either spontaneously or with treatment, then in fact your risk of liver decompensation, liver cancer, liver transplant or death, or the first clinical events, reduced by around 70%. So that's, I think, a significant indication that this surrogate marker of S antigen loss is actually an important one, and we should aim for that. So my talk is really about challenges and successes. Now you can see here the challenges far outweigh the successes here, and I'll take you through some of these challenges that we're facing in order to try and reach this endpoint. So the first thing is this complex natural history we have here. I think maybe more complex than HIV, and certainly more complex than Hep C. So when we look at this, at the bottom panel, you can see that there are 5 phases of chronic hepatitis B in those categories. The immune tolerant phase, now it's also called chronic hepatitis B infection, because the immunologists don't like using the word immune tolerance. Then we have the immune clearance phase, and EASL has redefined that as chronic hepatitis, chronic active hepatitis. And that phase is terminated with the development of E antigen seroconversion. So there's a marker called E antigen, which is thought to play a role in tolerizing the immune system to chronic hepatitis B. But after that, you get an inactive carrier stage down here, where the viral load is low and S antigen levels tend to be lower. And if there's no reactivation of hepatitis B during phase, then you have the possibility of developing functional cure. I said about 1% a year. And in cohort studies from Taiwan, you can actually reach as much as 50% S antigen loss in patients who are carriers. But that takes 25 years, so we don't wait too long for that to happen. Now, clearance of cccDNA and integrated HBV, of course, that's something that we hope for the future. Now, let's talk about the complex virology. So here is a schema of the life cycle of hepatitis B, and I just want to focus you on this aspect of chronic hepatitis B, which is the replication cycle here. And you can see here that After viral entry, the hepatitis B, which is a partially double circular stranded cDNA, recircularizes to form covalently close cccDNA, or a mini chromosome. And then it also can integrate into the host chromosomes. And these lead to production of enormous quantities of S antigen. And that provides us with what we call the secretory pathway. Now, that is different from the replicative pathway, which produces active virus called virions, which are infectious in nature, while the S antigen pathway produces something called subviral particles. And these viral particles are produced in excess to active virus to a nature of 1,000 to 10,000 times higher. So for one active virion, you may have something like 10,000 subviral particles floating around. So that pathway for S antigen production comes from both cccDNA and integrated HBV, while the replicative pathway produces the actual virions, which is then secreted through the multivesicular body. So with that in mind, keeping in mind that these two separate pathways, we also need to know that a lot of S antigens produced by integrated HBV, particularly in E antigen negative pathways. And this study was done in actually chimpanzees, where they found that integrated transcripts actually were were producing most of the S antigen, and that's been also found to be true in patients who had liver biopsies. We find that more than 60% of the transcripts from HBV S antigen were from integrated HBV. So that's very challenging for us to try and remove or to get functional cure when most of it is integrated. And we know that HBV is not the same as HCV because of this mini chromosome here, which is probably quite hard to remove. And I haven't shown you there, but there's also evidence that these are transcriptionally, these transcripts are also transcriptionally active, and they're dynamic in nature. They're controlled by histones and post-transcriptional modification of histones. There's also complex hepatitis B immunology. This is a study that was published by Sharon Lewin, actually going back a few years, showing you that there's impaired innate and adaptive immune responses in hepatitis B. And you can see that there's so many different aspects of the immunology, both in innate and adaptive immunology has been affected, that which ones should we try and improve? And it's not very clear whether adaptive immune responses actually are the likely source of hepatitis B functional cure. This is a study done by Antonio Bertoletti, who is a very well-known hepatitis B immunologist based in Singapore. And he's found that in more than 200 patients where they did HBV-specific T-cell responses, they did not find any relationship with low S antigen levels. And in fact, he found that this was related to increasing age. The increased T-cell responses was related to age, while you can see down here, when we look at the S antigen levels, there was actually a reduction in S antigen responses over time. However, this is still unpublished data, is under review in Journal of Hepatology, showing us that actually in liver biopsies of patients with hepatitis B, you can see here that in this part of the T cells, NK cells, innate immunity, there's actually an increase in this population with decreasing S antigen levels. And what is this population? So these are CD69 positive, which means they are resident NK cells. And these cells contain NKp46, NK2D, which are actually activation markers. So it seems that the reduction of S antigen levels leads to increased activation of NK cells inside the liver. And that might give us a clue that actually maybe innate immunity is more important than adaptive immunity. So of course, when we're looking at the life cycle here, they're all potential targets for hepatitis B therapy. And you can see here that they're both targets related to the virological life cycle, as well as targets that are immunologically based. And the fact that there's so many different targets tells us one thing, that we don't actually know which ones are going to lead us to the right solution. So let's give everything a try, and I'm going to take you through quickly some things that have worked and some of the things that haven't worked. So the rough approaches to hepatitis B cure strategically are these three approaches. Inhibit replication, which we're very good at with nucleoside analogs. There's a new class of agents called capsid inhibitors, which I think we are also able to use, which are in combination with hepatitis B, and I'll show you data on that and see whether that's useful. Lowering the viral antigen burden, and that's primarily the S antigen, because I've told you that that's 1,000 to 10,000 times higher than a single virion in the blood. And finally, to boost immune responses, and how are we going to do all that? So, based on that, what is the actual target we should be looking towards achieving this cure? So the S antigen I've told you is the key factor here that we're looking to try and remove. So S antigen loss is the ideal target. The trouble is that if you start with a low S antigen level in your patient, then it's easy to get a cure. If your S antigen level is 10 and your antiviral agent can reduce it by 2 log, you're going to get a cure in just about everyone. But if your viral antigen load or your S antigen load starts off at 100,000 or maybe 1 million, then a 2 log reduction in S antigen isn't going to lead you very far. So we need basically a combination of both. The baseline S antigen level tells us that the more potent the drug is, the more likely more people are going to lead to a functional cure. But to compare between agents, we probably need to use the potency of S antigen reduction rather than the S antigen loss rates. And I'll show you some examples of that. So here is a schematic diagram I've showed you looking at the different classes of agents and their combinations that will lead to S antigen reductions. And you can see here, a lot of agents are in the category of less than 0.5 log reduction. So it's not going to be very potent in terms of S antigen reduction. It includes nucleoside analogs, NA, FAMS or capsid inhibitors, and TLR agonists, which is a combination of immune markers and replication inhibitors. And the ones on the other end of the spectrum, more than a 3 log reduction, are antisense oligonucleotides, and I'm going to show you some data on that, and nucleic acid polymers. And in the middle is sort of a different class of agents that include siRNAs and interferon, as well as nucleoside analogs. So let me tell you what doesn't work, which tells you about the challenges. So these are nucleoside inhibitors, and everyone's using nucleoside inhibitors. 98% of the world's population on hepatitis B treatment are taking nucleosides. And you can see here that the nucleoside inhibitors have an ability to reduce both the correlated antigen and HBV RNA over time. HBV DNA reduces within a year. But the other markers for transcription take a much longer time, but very little impact on S antigen. You can see over a 5-year period of time. Now, these are capsid inhibitors with new class of agents, and you can see here very good at reducing the HBV RNA, and in E antigen positive patients, it can actually reduce the S antigen levels, but in E antigen negative patients, no impact. Why is that the case? Because E antigen positive patients, the S antigen levels come from the virus, cccDNA. In E antigen negative, it comes from integrated HBV, which the capsid inhibitors, being a replication inhibitor, has no effect on that particular pathway. What about combinations that don't work? And this is really quite an interesting study called the REEF-1 study. And the REEF-1 study basically looked at here the combination of different classes of agents, capsid inhibitor, nucleoside analogs, and siRNA in combination. It's a triple combination. We think that that's probably the most potent combination, versus in blue, the siRNA plus the nucleoside analogs. And what's surprising is that the dual combination was better than the triple combination. That's mind-boggling. How can that be? And I think it just tells us that what we expect to happen doesn't always happen in real life. You have to test them in clinical trials. And unfortunately, because of this setback, Johnson & Johnson have decided to withdraw from the hepatitis B development market, which is unfortunate for all of us, because I think actually their agents were actually reasonable, that they felt that this was a major setback for them. And this, in fact, if you look at the triple combination, the percentage of patients who reached a level of less than 100 was less in the triple combination than the dual combination, confirming what I've said. So let's look at some successes. We need to boost ourselves up now with some happy stories about what's going to work. And this is a new class of agents. Some of you may have known these, antisense oligonucleotides and siRNA. They're slightly different, although they're both RNA interference. Antisense are what they call naked RNA. It's not double-stranded, it's single-stranded. And while siRNAs are double-stranded, and they go through the RISC complex, while the antisense goes directly to either the liver or the kidneys. And I won't bore you with all the details of the mechanism of action, but to show you that first results from bepirovirsen, which is the antisense from GSK, was published in New England earlier this year. And it's a phase 2B study, and the reason for this is because of the exciting developments shown here. As I said, it's a phase 2B study, so I just highlight to you that the best results were in that orange bar. 24 weeks of bepirovirsen at 300 milligrams with a loading dose. And here are the results from patients on nucleoside and not on nucleoside analog. And I would highlight to you the orange bar here again on the left-hand side, showing you basically, this is the end of treatment, but at the end of follow-up, basically the results showed about 10% S antigen loss in the on-nucleoside arm, and 9% in on-nucleoside arm, and 10% on the not on-nucleoside analog arm. And what we showed, what we also find is that the baseline S antigen level is the one that's got the strongest predictor of S antigen loss. So if you have a S antigen loss, S antigen baseline less than 3,000 IU per mil, you actually have a 25% chance of S antigen loss, which is extremely promising. Now, on the other hand, these are the siRNAs. This is the J&J one with 3 shots, which is 1 month apart. The bepirovirsen was given weekly, by the way, for 24 weeks. This is only given 3 doses, 1 month apart. And you can see in the orange line, the responders showing that after 3 shots, there's basically low S antigen level that's flat for a year. Unfortunately, no S antigen loss. So they can get sustained S antigen reduction, but no S antigen loss. And in this study from another company called Vir, they also had an siRNA, and they combined it with interferon. And you can see here in the red line here that they get 31% S antigen loss if you're given 48 weeks of interferon together with the siRNA for 24 weeks. So it's possible to get decent levels of S antigen loss, but you need to combine. So just to summarize, people, for you guys, antisense therapy leads to 90% S antigen loss at the end of 6 months follow-up off antisense therapy. Now, what is most important here is that the efficacy was similar in nucleoside-treated or untreated patients. In other words, the antisense therapy as monotherapy could lead to 10% S antigen loss. And in fact, if your S antigen levels was below 3,000, that S antigen loss rate was 25%. siRNA on its own with nucleoside, no S antigen loss, you're getting about a 2-log reduction in S antigen. But if you add in interferon, you actually can get up to 30%. But these are very small studies, I should say, so we need to show it in better studies. One class of agents which has not been reported widely is this nucleic acid polymers. And these nucleic acid polymers, you can see in the middle panel here, upon the introduction in a clinical trial combining tenofovir, interferon, and REP, which are nucleic acid polymers, every time you introduce it, you get these dramatic reductions in S antigen levels around 3 log. So they do appear to have a lot of potency, and you can get functional cure in 40% of these patients who completed 48 weeks of follow-up. What about immunotherapy? Where does that come in? So this is GSK's selgontolimod. It's a TLR8 agonist. And you can see here that in the right-hand panel at 48 weeks, in the green bars, you're getting significant reductions in S antigen level. But overall, the S antigen reduction was less than 1 log, probably less than 0.5 log. 2 patients had S antigen loss, but they actually had very low S antigen levels to start with. PD-1 inhibition, yes, you can do that. And this is with nivolumab. And 1 patient lost S antigen out of 24. The therapeutic vaccine GS4774 had no effect on that. And it's a follow-up study of the PD-L1 antibody, ASC22. This was tested in a phase 2B study. You can see here that the doses were given every 2 weeks for 24 weeks. And what you had is that you had a median S antigen reduction of 0.38 log, but those who had less than 500 IUs per mil had significant S antigen loss. So overall, 9% achieved S antigen loss by week 24. Target engagement was very good. And actually, there were safety profiles that now has been reported to have significant thyroid adverse events in 30% of patients. So not necessarily something that you want to do. So just to conclude, functional cure is an achievable endpoint associated with improved clinical outcomes. However, significant challenges remain in the virology and immunology. cccDNA eradication or silencing strategy is unclear. Viral integration produces significant S antigen levels, especially in e-antigen negative patients, and immune mechanisms of cure are unclear. Challenges in therapy are considerable. Nucleoside analogs, capsid inhibitors, no effect. Interferon can lead to functional cure, but only in 5% with significant adverse events. Successes so far limited, but promising. The anti-sense oligonucleotides lead to S antigen loss in 10% as monotherapy and as high as 25% in those with low S antigen levels. And nucleic acid polymers can lead to 40% S loss, but in combination with nucleosides and PEG interferon, and similar with siRNAs, you can lead to high rates of S antigen loss, but you still need interferon. So quite likely there are multiple pathways to achieve functional cure. And although there are significant challenges, I think we're seeing enough data that promising approaches could lead to higher cure rates. Thank you very much for your attention, and just to encourage you to attend Hepatitis B Cure meeting next year in Singapore if you are interested in cure, July 26 to 28 at Grand Hyatt. Thank you very much.